Welcome to this lecture on what we do with the really big or massive rotator cuff tears. Can we repair them? And if we can't repair them, what do we do next? In this talk, I'm going to look at four main areas related to this subject. The first is, what do we actually mean by a massive rotator cuff tear? The second is looking a little bit at the evidence around what can we fix, what are the results of fixing these things, can we predict what the results are going to be, and do we actually need to fix them? We'll then look at techniques you can use if you decide that you are going to attempt to fix a very large rotator cuff tear. What can we do? Does it actually work? And then finally, we'll look at what do you do if this thing is unreconstructible, you can't repair it. Is there anything else that you can do? So if we start with, what do we mean by a massive rotator cuff tear? There are all sorts of definitions of large and massive rotator cuff tears. Predominantly these are related to size, but do we mean the AP diameter, the amount of retraction, the number of tendons involved, or even the quality of the tendon? A debate on all of these is somewhat beyond the scope of this talk. So I think for the purposes of what we're talking about an AP diameter of more than 3 centimeters, retraction of at least the tendon back to the glenoid, the involvement of at least 2 tendons, and significant fatty degeneration when you look at the Guettalier grade. So we're really looking at the grade 3, the grade 4 fatty infiltration. And this really is what we mean by a massive rotator cuff tear. So we'll now go on and look at, should we be attempting to repair these things? What are the likely outcomes? So the first question is, should we actually be attempting to repair them? This is the scan of what we would probably agree is a pretty large rotator cuff tear in a 78-year-old woman. And as you can see from the video, actually she moves the arm pretty well. She's got an excellent range of motion, she's got good rhythm, she doesn't have any pain. And in case you're wondering, the affected side is actually the right side and not the left. So we don't have to fix every tear just because it's there on a scan. Over the years, there have been all sorts of attempts to try to predict tendon healing. And the thing that a lot of people are talking about now is this Rohe score based on the parameters that you can see. And on the face of it, it looks great. You put the numbers in and there's a calculator and it gives you an answer. In practical terms for most of us, first of all, we don't have bone mineral densities. So we can't use that bit. And secondly, when you look at it, it's almost self-explanatory. Older patient, larger tear, significant Guettalier changes, and high activity, they're probably not going to do well. You don't need a calculator to tell you that. So I'm not sure quite how useful it is in day-to-day practice, but people are talking about it and people are aware of it. And probably something like this is going to be built that will work in the future. If we now look at techniques that you can use if you've decided you are going to do some form of repair on this very large tear. The premise behind doing this is this concept that Burkhardt developed of what a functional rotator cuff tear and an unbalanced tear is. So a functional one, and I'm not going to go through all the details, it's got to be balanced in both the coronal and the transverse planes. This suspension bridge has got to be intact, And there's got to be a minimal surface area for the tear. So it says, can you make your tear smaller? If you can do all of these things, then maybe your tear is functional and the patient is happy with the outcome. The tear becomes unbalanced if the force couples aren't the same. So either that's sort of subscapularis and infraspinatus are unbalanced, or you don't have the superior control, any one of these, and the shoulder then doesn't move with any sort of control, and you get the symptoms. So if your rotator cuff tear goes from balanced to unbalanced, you become asymptomatic. And if you can't reconstruct the balanced form, then probably whatever you do is going to fail. So the first thing we're going to look at is what's called partial repair. So this is putting together what you can put together. Now this is difficult because this is going to be very variable depending on the tissues, and the data, as you'll see, is not fantastic. So this is a slightly older patient, unmatched groups, but roughly the same, some with complete repairs, some with partial repairs, and in this group, no significant difference in the outcome. Another option is to do what's called margin convergence, where you convert a large retracted tear into a slightly smaller tear that looks like something that in theory would be repairable if you just had that little bit more. The concept behind this, as Burkhardt said, is that the tear must occur through a minimal area. So does this actually work? The answer is it's very difficult to know, because most of the time you do a margin convergence and something else. So there are very few studies that look at pure margin convergence and nothing else. And as you can see, rather small series, but 13 out of their 14 patients were very satisfied, whatever that may mean. So there probably is something in doing this, but it's difficult to prove that it actually is the answer to the problem. Another option which runs alongside margin convergence is this thing called an interval slide. This is where you release the scar tissue between the supraspinatus and infraspinatus up at the spine or around the coracohumeral ligament and the coracoid, with the idea of dragging the tissues forward and then doing some form of slightly better reconstruction. The theory here is that you turn what would be a big retracted U-shaped tear into something that you could probably do a margin convergence or get something back to bone. So do either of these work? Again, small series, somewhat uncontrolled. One group where they did interval slides and got a complete repair, and another group where they did a margin convergence, and actually there doesn't seem to be any difference in the outcomes. So the answer is probably if you do something with these in some patients, it'll work. The difficulty is we don't know exactly which patients you're going to get the good results out of. So now we're going to move on to what do you do if you're not going to do these things? Is there anything else that you can do? Well, the answer is there are quite a lot of things you can do, and we'll go through them. So you can put a patch on there, and we'll talk about different types of that. You can augment your repair with a biceps. And failing that, when you've got more damage, you could do a superior capsule reconstruction. We'll talk about these balloons, tendon transfer, or ultimately a reverse total shoulder replacement. And we'll go through some of the evidence for these. So if you're going to use a patch, you can do this as an onlay, which is a sort of reinforcement over the top, or as an interposition, so a bridge between the end of your rotator cuff and the greater tuberosity, or you can use the biceps and somehow cobble this into your repair. And there are lots of different ways that you can do that. So these are all potential options. So as I mentioned, the first form of patch is a sort of onlay, where you do the repair and then bring your patch, either incorporating it under the sutures or on top of the sutures. And you can do this with fascia lata, or you can do it with some form of allograft. Either way, there are some good results, but this is somewhat dependent on you being able to get your tendon back onto the bone in some shape or form, rather than leaving the patch just sitting in space. Another option, if you can't get your tendon back onto the bone, is to use this interposition graft, where you attach the graft to the end of your tendon and then just attach the graft to the greater tuberosity. And as you can see from the data here, really some very good scores, going up to a post-op Oxford score of 46, which is really stunningly good. And this looks very attractive. The only thing to say is this is done out of a fantastic group in Leicester. Nobody else has been able to reproduce these results. Now, I'm not saying that they're doing anything wrong. I just think that they're doing something very, very right that none of us have been able to reproduce. More recently, people have got very interested in using the biceps as an augment. This has the advantage over those patches that it's a lot cheaper, it's local, and you can either do it like you see in this picture, where you cut it, you can reroute it, you can detach it completely. You can use it on its own, as you see here. You can cobble it into your repair, partial repair. There is all sorts of stuff out there, all sorts of options, and some very good published data with very low re-tear rates. But it's very difficult to know because all of these techniques are slightly different. Everyone's got their own twist on exactly how they do it. So trying to compare it and work out what is the right option, as yet we don't really know. So what do you do when it's too far gone and there is absolutely no chance of being able to do a repair or one of these patches? So I'm just going to mention a couple of techniques just to get them out of the way. The first one is this concept of this biodegradable spacer balloon, which was advertised as the solution you've been waiting for. And there were lots and lots of papers published on it. And unfortunately, they finally ran a trial which was abandoned because it was inferior to debridement. So that's all I'm going to say about the balloon. I think it's had its day. People are still doing it, but it doesn't really work. Another thing you may hear about is biological acromial resurfacing, where you put a patch on the tuberosity and another patch under the acromion. There have been a couple of papers published, both by the developing surgeon. One's a technique description, one's biomechanics, but as yet, we don't have any clinical results. I'm assured there are some coming, but it's really very difficult to promote this as a concept until we see some evidence in a randomized trial that it actually works. So I'm now going to look at the more evidence-based options, and this is the superior capsule reconstruction, tendon transfers, and ultimately reverse total shoulder replacement, which is an option for the purely cuff deficient non-arthritic shoulder. Just to orient you during these next few slides, this is a diagrammatic representation of the shoulder with the tendons, and we'll see how the different patterns line up with the different tendon treatment options. So the first one we're going to look at is the isolated unreconstructable supraspinatus tear. So intact infraspinatus, intact subscapularis, absent supraspinatus. This is probably the place for the superior capsule reconstruction, where you graft from the greater tuberosity onto the glenoid. Like all of these tendon operations, this is for the younger patient, the 50 to 70-year-old, ideally the non-smoker, not a revision case. This one is purely the isolated supraspinatus, and if you are going to do it, I would just give you a caution: be wary of a slightly ropey looking infraspinatus, because it will probably fail on you down the line. And the concept here is that you're coupling the front and the back through the middle. So you need everything working. There's been a lot written about this technique since it was first described some 15 years ago by Mahata. You can use fascia lata, you can use an allograft, there are all sorts of different fixation techniques, and these have evolved. As I mentioned before, you can use the biceps. What we know is that it does seem to work. It does improve functional scores, range of motion, pain scores, but it doesn't give you strength. And it seems to last. There's certainly be some good 10-year data coming out that says it's sustainable. It probably starts to fail at 10 years or beyond, but hopefully that's taken the patient into a phase where you can consider something else like a reverse total shoulder replacement. If we now move on to the even bigger tear, so this is the loss of the posterior superior cuff, so supraspinatus and infraspinatus, but an intact subscapularis. Really here, there are two tendon transfer options. There's the latissimus dorsi and the lower trapezius. And I'm not going to go into a lot of technical details, but I just want to talk a little bit about the pros and cons of each one. So the lat dorsi transfer has really been the staple for many years. We know that this works. It's a very good head depressor, and depending on where you put it, it can give you more or less external rotation. The slight downsides of it are that technically it's quite difficult to do. You have to be rounding the axilla, you're very close to the axillary nerve, and it's hard to mobilize. It also can be very difficult for the patient because you're turning what is effectively an internal rotator into an external rotator, and some patients just can't do that. And although you can get very good results, as you see here, there is evidence that about 25% of the patients are unhappy with the result. An alternative that's appeared in the last few years that came out of obstetric brachial plexus surgery is the use of the lower trapezius. This is where it's detached from the lower border of the spine of the scapula, and then an Achilles tendon graft is inserted to make up the difference. The upside of this is it's much easier to do, much less chance of damaging any major nerves, and the patients find it easier to understand an external rotator becoming an external rotator. The big downside of this operation, like a lot of these grafting operations, is the Achilles tendon allograft is very expensive. It's in the order of about £2,000 or more a time, so there is a big cost implication. We now move on to the even more complicated tears where you've lost supraspinatus and or infraspinatus as well as the subscapularis tendon. So you now need to replace two tendons. So there are a couple of options here. One is to use either your latissimus dorsi or the lower trapezius to replace the infraspinatus and the supraspinatus, and use the pectoralis major to transfer it across to the subscapularis. And this can be done either over or under the conjoint tendon. Not bad results, but it does have about a 12% failure rate, and 50% of patients weren't very happy with the results. And biomechanically, the pec major is not a great option for this. But it is there and it has been the staple, and there are long-term published results for it. Another option, which biomechanically probably makes more sense, is to use the lower trapezius and the Achilles tendon allograft to do the supraspinatus infraspinatus part, and that then frees up the infraspinatus to be able to swing it up to the lesser tuberosity. This is a very short excursion, and you've got a nice internal rotator with a very, very similar range of motion and direction of motion. Again, clinical failure, roughly the same. We just don't have the numbers to really know, is this a good option? And I can tell you from personal experience, patients struggle having both of these things done. at the same time. So possibly this is an answer. I suspect it's never going to be a very good option for these patients, but maybe in a younger patient it's worth a try. Finally, we need to talk about the possibility of using arthroplasty, or reverse shoulder arthroplasty, which is what we would use for a patient with arthritis and a massive cuff tear. More and more patients are being treated with a reverse arthroplasty with no arthritis. So is this a good idea? Well, actually, if you look at the recent meta-analysis, the complication and the revision rate, if you do it as a primary procedure, actually very low. Of more concern is if you do it as a salvage, having already tried to do a cuff repair, that actually your infection rate is not great. So maybe we should be thinking about doing this as a primary procedure. The concern, of course, is if you've got a 50-year-old, do you really want to be putting a reverse arthroplasty into them? And this is territory we just don't know the answers to yet. Do you go primary reverse, accepting that it might fail within 10 to 15 years? Or do you hang on, do your tendon transfers, and accept a higher complication rate later on? This is uncharted territory. So in summary, this is the problem that we're faced with. The very large, massive rotator cuff tear in the symptomatic patient. This is our solution. We have a variety of options, from some form of partial repair to a superior capsule reconstruction or a biceps transfer or some form of tendon transfer or a patch or even some form of shoulder replacement. What we know is that what we do is dependent on all of these factors. So there are age and patient-related factors like comorbidities, the number of tendons involved, the function of the patient, what do they want? Also, we have to bear in mind what our individual surgical skills and experience are. Some of these operations are difficult. They need experience, they need practice. And then there's cost. How much do you spend on your patch and on your graft? Or do you get a cheaper option and just go for the arthroplasty? But again, that's not cheap in itself. So we have to factor all of these things in, and each independent patient becomes an individual. What I think you need to bear in mind is that really you get one shot. You have a whole bunch of bullets, lots of different ways of treating this. You've got to pick the option that is going to be the best for your patient the first time, because we've seen complication rates and difficulties go up if you're having to do redos because it didn't work at the first hit. Thank you very much for listening.